Hello and welcome to this Tessera Clinical Education Oncology podcast. I'm your host, Jervis Constanzo. In today's episode, we're joined by Beth Sandy, who is a thoracic oncology nurse practitioner from the Abramson Cancer Center of the University of Pennsylvania in Philadelphia, Pennsylvania, and Denise Rouse, a physician associate in thoracic medical oncology and Department of Medicine at the University of Chicago in Chicago, Illinois. Together, they will be discussing the role of advanced practice professionals, APPs, regarding biomarker testing in patients with lung cancer. This episode is part of a larger educational program entitled The APP Guide to Actionable Biomarkers in Solid Tumors, Reducing Barriers, Promoting Confidence, and Leveraging Genetic Testing for Informed Treatment Decision-Making. For more information on Beth and Denise, along with a link to the complete program, including downloadable resources, clinical commentaries, and educational podcasts for colorectal and prostate cancer, please visit the show notes of this episode. Now let's hear from the experts on the role of APPs in biomarker testing in patients with lung cancer.
You, Jarvis. I'm happy to be here together with Denise today to cover this very important and exciting topic about biomarkers in non-small cell lung cancer that has really changed the way we treat lung cancer. I have been a thoracic oncology nurse practitioner for over 20 years. And, back 20 years ago, we didn't have these biomarkers to test for. As a matter of fact, pretty much everyone that came through the door was getting paclitaxel and carboplatin. It was really the only thing that we had to treat lung cancer. And now we've come so far. And particularly what we're talking about today is identifying all these different biomarkers that are there in non-small cell lung cancer and then how we can give the appropriate treatments to target these. And patients can live so much longer with a better quality of life that we've seen over and over with the different biomarkers that we find. And sometimes, Denise, it's even to the point that I look back and I think about my young patients. Particularly, I feel like, 20 years ago, I would have these young women who were never smokers coming in. They were 30, 35 years old. And we didn't know that their lung cancer was probably very different from a lot of other lung cancers. And unfortunately, a lot of them died within like 9 months of treatment because all we had was chemotherapy back then. And now I think about them and I think, man, they probably had one of these, mutations or biomarkers that we could have targeted and we just didn't know. And sometimes that haunts me a little bit, but I'm so happy now when we're able to find one in whoever it is, whether they affect all types of patients, these biomarkers. But it's so exciting when we can find one and really personalize our therapy. How has this been for you, this biomarker testing experience over your journey as a physician associate?
I feel the same way. It's heartbreaking when earlier we would see patients, they would come in, they wouldn't respond the same way, maybe if they were a younger, never smoker. And it was always really difficult to see these patients go through this process. And now we have these biomarkers, which are changing really quickly. We're seeing new biomarkers every few months, 6 months. And now it's really exciting. It's what makes this kind of fun and exciting. We have so much more to offer. It's so interesting. We have so much to learn. But I think it's what also makes it overwhelming. It can be really hard to keep on top of all these biomarkers. And I think about the people in the community who are seeing multiple types of cancer. And I am just so amazed and impressed that they are able to manage so much. I have the privilege of being able to focus just on thoracic oncology, but this must be really overwhelming at times for our
I
community
agree.
partners.
I don't know. That has to be so hard if you're seeing multiple different tumor types. Let's talk a little bit first about what biomarkers are we actually testing for in patients with lung cancer. It's just like you just said, Denise, this has changed so much in the past 5 to 10 years. I mean, I remember I was looking back at one of my long-term EGFR responders and I saw the requisition that I had sent, which was handwritten, maybe, I don't know, 12 years ago. And the only thing I tested for was EGFR and ALK. And I thought, well, that's all I knew about back then. I didn't know anything more, but now we know so much more. I'm interested to ask you, I'm assuming you do a full next gen sequencing panel in non-small cell lung cancer. You don't cherry pick out different biomarkers. Would I be right to say that?
Yeah, no, that's absolutely true. We definitely do full NGS, full next generation sequencing. And the part of the process that makes this more efficient for us is it's reflex testing. So to get that tissue, we see it's a lung cancer, we're going to have reflex testing that's performed. So that way we make sure people aren't falling through the cracks.
Yeah, agreed. And even at my institution, we've developed like a smaller panel that we get quickly that has what we would, I guess, consider the essential biomarkers, the ones that we have known established targeted therapies for, such as EGFR ALK, ROS1, RET, MET, blinding BRAF, V600E, KRAS, and then the really outliers like NRG1 and NTRK. But it'll do like, I think it's a 30 gene panel, and we get that a little bit quicker than the full panel. Then we reflex to that, of course. But timing is always an issue. And we're going to get into that in this podcast of how timing can be such a barrier and so difficult for patients. I guess another thing I wanted to ask you is, can you explain to our listening audience what the difference is between a germline mutation and a somatic mutation or a biomarker? Because I think those terms get thrown around a lot. In lung cancer, we see less germline. You may see that more in things like breast cancer or gynecologic type cancers. But can you explain to our audience what the difference between those two terms are?
Yeah, it's really important because often, right, the patient comes in, they find out they have cancer, and then they immediately think, what about my kids? Is my daughter, is my son going to inherit this? And so it's important to understand the difference between germline, something you're born with, it's inherited, that can be passed down to the next generation. And we need to be thinking about, screening and how do we protect that next generation versus somatic, which is what most of our lung cancers are, the vast majority, and those are acquired. Those happen over time. You're not born with them. You pick them up as you go. There's a change in your cells that forms the cancer. You're not going to pass that on to your next generation, and it's not going to affect your family or those around you in terms of seeing it forward. I've actually had people also sometimes be worried, could they give their cancer to their family member? I don't know if you've ever seen that, but sometimes, people are
Absolutely.
scared and worried.
They are,
And
they are. Yeah.
yeah.
I
And
mean,
so
like parents will be like, say, "Oh, you have an EGFR mutation." I'm like, "Oh my gosh, my children, like, are they going to get this too?" And we can confidently say to them that no, EGFR, ALK, really most all of our, biomarkers that we have targeted therapies for, these are somatic. These are not something that are hereditary and passed down to their children. I've seen patients in the clinic breathe a sigh of relief, and even sometimes their children that are sitting in the room with them, because that can be really a difficult thing to think about.
yeah, absolutely. I do think that that can be a real challenge for families. And sometimes it allows them to shift the focus a little bit more to their cancer, what they're going through, because I do find that patients are often almost more worried about their children, about, what's going on, how this could affect them. And I do think it allows them to say, okay, this is just me. Now we can work on this.
Right. So the implications of this testing for our clinical practice and the way we develop treatment plans and certainly patient outcomes all comes into play here. So, when we get one of these biomarker tests back and it shows that there's an actionable mutation, did he maybe walk me through how that conversation might go between you and a patient? Let's just take, for example, maybe an ALK gene rearrangement. If that comes back, how does that look for you in your practice when you might be talking to a patient about that?
Yeah, and so that's a part of the role that we play is we do a lot of education as APPs at my site, and I think that that's pretty common. That APPs are educators, and we spend a little more time sometimes answering those questions that people have after their diagnosis. And with the biomarker testing, we talk about, let's say, ALK. What we talk about is that we have found what is driving your cancer, right? We talk about these targetable mutations, these driver mutations. So we have seen with this testing what in your cell is not working properly that is allowing your cancer to grow. And the good news is that we have a drug, in this case, it would be an oral pill that you would take to target that very specific area that is causing the cancer to grow, and that will be monitoring you. And we find that people tend to respond better. We can manage the side effects, and they tend to have less time in the clinic and live longer. Right. And so I think one of the challenges as we look at all these biomarkers is also all of the different drugs that we have that target them, which we can talk about later, also have different side effects and different monitoring profiles. And so I'll usually, in the very beginning, make sure that I go through what is our monitoring plan and what are some of the side effects you could anticipate when do you call us.
Denise, I think that was an awesome description of how you talk about this with a patient, because what I loved about what you said is how you took it down to a level that patients can understand. You're not sitting there using big words and saying the way that these genes are rearranged within your cell are going to cause, driver growth. That you're not like throwing these big words out. You're saying what it really is that we've identified this, you know, thing, this protein that's within your cancer that's helping drive your growth of your cancer. And we have a pill that we can target that with. And because most patients think about lung cancer, they think chemotherapy. And thanks to television commercials, they think immunotherapy, right? And
True.
right. So now they're thinking like, oh, why aren't you giving me something IV in my arm? But, we get to say to them, no, I mean, you can take this pill and this has been studied. And if you compare this to chemotherapy or immunotherapy, you do much better on these medications that are targeted towards this biomarker that we found. So I think keeping it on that patient level is really great, and reassuring them that the outcomes are better. And we know this based on clinical trial data, that these outcomes are going to be better than something IV we're going to put in your arm or something you may have seen on television, which works great. I remind patients, hey, that works great for a whole subset of patients who don't have your specific type. But yeah,
So,
and pill thing too
no,
is big, right?
yes. Oh, and it's so tell me, how do this is a real common thing we see, especially in this day and age. How do you handle patients who come in with doing their Dr. Google research and saying to you, but wait a minute, I saw though that this immunotherapy, that these drugs, I should get this because I saw my PDL1, it's high, and I can see that it's really important. So why would you not give that to me along with this pill?
I literally had a patient come in one time with the name of an immunotherapy drug on a napkin and that still had a coffee stain on it. And he said, I was meeting my friend and he wrote this down on the napkin for me because he thinks I should be getting this. And I said, well, that's a drug that works great sometimes for lung cancer, but you have this EGFR mutation. So you're in a better group because you get to take this pill that works even better than that. I know it's, been advertised and it, like I said, it works great for some people, but this is not for you. But yeah, patients will certainly, sort of, I think, gravitate toward that.
And I do find as well that when we get these targeted mutations, and I have these what we call at our site sometimes the Dr. Google who is weighing in on these things, it we do have some really good organizations out there that people can get good validated information. It's a people who are really interested in more. I will sometimes refer them to longevity or some of the targeted groups like an EGFR resistors, and most of these have those different groups where they can talk to people who have the same type of cancer and they can get better information.
Sure. Yeah. The KRAS kickers, the Ross Wonders. I love it with their names. They've come up with great patient advocacy groups. So let's dive into some of our themes that we've seen within biomarker testing. And I'll introduce this. We did a survey because we wanted to survey some other advanced practice providers who are in oncology to kind of see what they have experienced as far as biomarker testing, as far as barriers to testing, how we interpret testing, what our role in treatment decisions are, and so forth. So we're going to walk through some of these and introduce some of the data that we saw. We did this basic survey, and there were 39 people who responded. About 25 of those were nurse practitioners and physician associates. So we're going to sort of stay on the data from that subgroup. And out of that subgroup, about a little over 50% of those of us saw the majority lung cancer patients, and then the other 50% saw a little bit of a mix of everything. So I think we got a good representation of these barriers and different things that we experience in practice. So let's sort of talk first about some of our barriers with testing integration. And I think, Denise, you and I could probably spend a half hour just on this topic. It seems so easy, right? It seems like, yeah, just test all of your patients for this broad molecular panel. Just do it, and then you'll have the results and be able to start your treatment. But at the end of the day, it's sort of not that easy. And to be honest, in our testing results, only about 50% of our APPs said they are routinely doing the full NGS panel. Some of them were doing other piecemeal panels. The majority of people were doing some sort of testing. But I think you and I were both taken aback by that number, right? I mean,
Yes.
we feel like it should be 95, 100%. So what do you see and what did you think from our data are some of the main barriers?
I think one of the easiest ones to answer is identifying which patients to test. In the guidelines, we test everyone, but stage 1B for your metastatic, stage 4 is everyone. We shouldn't be using clinical pathological features to test. We don't just test non-smokers. We don't just test a younger patient. Everyone should get testing because starting at stage 1B, there are some mutations we find that are actionable even for those early stage resectable patients. And so that should be the policy. That should be the standard that you have.
Denise, do you guys do reflex testing at your institution?
We do. And I think that that's one of the things that can be very helpful to have reflex testing so those people aren't falling through the cracks.
Yeah, and what that means for anyone listening is that reflex testing means that in your pathology department, as soon as the pathologist reads a specimen that is non-small cell lung cancer, now at my institution, we only reflex the non-squamous patients right now, whereas other institutions may do everybody with non-small cell lung cancer. But our institution, we reflex the patients that are not a squamous. So that's going to mainly be adenocarcinoma, but it would also fall large cell or not otherwise specified. But any patient that gets that pathology read, the pathologist is immediately going to send this for biomarker testing. They're not going to wait for an oncologist or a pulmonologist or someone else to order the test. They're going to automatically start the testing. And I think that does relieve that barrier. Well, that relieves a lot of barriers, one of which, like you said, is identifying who to test because we're just going to test everyone. It also helps with the timing. I think we should probably go into turnaround time. 39% of our responders said turnaround time is a huge barrier for them. If you sit in front of someone, a patient in the office with stage 4 non-small cell lung cancer and say, hey, listen, I'm going to wait a couple weeks until I start your therapy. This doesn't go over real well. How do patients respond when you say something like that, Denise?
Oh, it's definitely true. I mean, the patients, they're like, but you got to do something now. I have cancer in
Right.
my liver. I have cancer in my lungs. And it's very panicking. Sometimes the family is even more panicked. But that is pretty standard. It takes 2 or 3 weeks for us to get these next generation sequencing results. That's going to happen across the country. So it's not like they're going to go to an institution across the street who can get it for them in 3 days. And so it does take time. And it's really talking about we want to make sure we get the right medicine for your cancer. We want to make sure we're personalizing that treatment to make sure that you're getting a treatment that your cancer will respond to. And if we wait, we'll get all of the data to make those choices.
Yeah, agreed. Let's talk about some of the other barriers as well, because I feel like there are so many. I think we'll spend a little more time just on this topic. Have you run into like cost or reimbursement issues?
Yeah, that's really interesting. And I think this goes into disparity as well, because one of the studies that I've seen recently has mentioned that sometimes providers aren't ordering the testing because it's very expensive testing because they're afraid that there's going to be a cost burden to the patient that they can't manage, right? But so in Illinois, I work in Illinois and we're really fortunate here. We actually have had state legislation that Medicaid and all of our state funded insurance programs are mandated to cover biomarker testing.
I love
And so
that.
It's really helpful. And that is something that advocacy groups are trying to enact. There's other states across the country. So we know our patients that are on Medicaid that are the patients maybe we're most concerned about coverage, it's going to be covered. So that's taken care of. And a lot of the testing, these things, they're covered by Medicare. A lot of the commercial carriers follow that. I don't think there's as much of an issue of coverage as they used to be. Copays are a different issue, but our social workers can sometimes help us with some additional resources to help if there is a large copay that needs to be paid. And most of the time, it's covered well. What about you?
The testing companies that we use, I mean, we mainly do ours in-house, but
Mhm.
the liquid biopsies we still send out. And within those liquid biopsy testing companies, they have a policy. They're never going to balance bill someone more than $100. And even
Yep.
within that $100, they've said, you know, if they can't afford it, we're not sending anyone to collections. We're not doing any of that. You know what I mean? Like they're just not aggressively going after this. So, those companies want to be paid too. They're going to do the legwork for you to fight the insurance company and say this was appropriate. But that was one of our big respondent answers was the concern for cost. And then the last one I'll touch on was our biggest one. This was the most common barrier identified in our survey was insufficient tissue. So what are you
Oh,
going to do? I know you get this result back and I'll see this sometimes with pleural fluid. If patient has a pleural effusion, it's a quick easy way to get a diagnosis. You drain the effusion. But a lot of times there might not be a lot of cellularity to that and the ability to get a good DNA extraction is not great. So you have insufficient tissue. What do you do in this situation? So hard.
it is so hard. And, if we have a metastatic patient, this is where liquid biopsy can give us additional information in that setting. Although for our metastatic patients, liquid biopsy should be being run along with our tissue biopsies. But it is really hard. And so we have to look at, can we get another biopsy? Can we get better tissue? And sometimes that's just institutional as well as working, our teams working with each other to try and maximize the tissue that they can get and send to pathology. What do you guys do?
All depends. It really does. So if we have insufficient tissue and a patient is sick and they need to get started right away, we're probably going to honestly start them on chemotherapy, not immunotherapy. The immunotherapy is what we want to hold off on because we want to for sure know biomarker status before that. Maybe get some chemotherapy on board. Find a new place to biopsy to get sufficient tissue and get as much of a rapid turnaround. I think this is also a great place for liquid biopsy because you can, send off the circulating tumor DNA within a liquid biopsy. Now, the problem is if that comes back negative, that might be a false negative because sometimes there might have not been, if there's not a heavy disease burden, you might not have a lot of circulating tumor DNA. So I think it all depends. I think another thing that depends on it too, and the waiting part is what are their clinical features? Now, we just said we want to test everyone, which is absolutely true. But if I have a young never smoker in front of me, it is probably likely that they have some sort of actionable biomarker. So I may be more inclined to wait if I can to get that new biopsy. I certainly want to send a liquid biopsy right away on those patients. But I think this has been one of the biggest barriers. It was certainly in our survey identified as the biggest barrier to getting the testing done. I think anytime somebody drains an effusion or gets a very small biopsy specimen, we have to rethink that and say, hey, listen, I need a good specimen here because I know it's going to affect my treatment.
And you brought up a really good point that I think is so important. We've actually, in the last month, we've had two patients come to us from outside institutions that were started immediately on chemotherapy and immunotherapy. Biomarker testing was done, and then we found that they had EGFR mutations. And so it is really important if a patient needs treatment, let's get them some chemotherapy. Let's get them some relief while we're waiting for that biopsy to cook and give us results. Because if they do have some of these mutations, we could really be depriving them of their next best therapy because they can have increased toxicity when we add on these targeted therapies. And immunotherapy often doesn't work as well in these patients.
Absolutely. Yeah. And if you give the immunotherapy, you can't take it back. It's like
Right.
6-month half-life. So that's why I say don't give the immunotherapy, just give the chemo. Because if the immunotherapy is on board and then you have to switch to a targeted therapy, there's often a lot of toxicity. It's fun and just spend a couple minutes on interpreting these results. Sometimes I think you need to be a rocket scientist. Denise, what do you think?
It is so hard. And that's
Trying
really,
to
I
read
think
some of these. I said, what is with the numbers and the letters, people, and the underscores and like the stars?
it's literally a different language. It's a foreign language. These are not terms that we understand. It's not things we usually do. I think one thing to realize is no one has memorized all these mutations. No one has this all down. So if you can just get comfortable with the most common mutations, at least with the list of targeted mutations that we have, that can really help you. And you can start there. And it's also okay to say to someone, I'm not sure what this means, but I'm going to take it to my molecular board and make sure that we get the right interpretation and we get the best treatment for you. Or to
Agree.
my multidisciplinary tumor board. It's okay to
Yeah.
tell your patient that because they want
Yeah.
you to do the right thing.
Beth, one theme that really stood out in the survey was that many APPs don't feel fully confident when it comes to the different targetable mutations. So I thought I'd give a quick high-level overview. For today, I'm going to refer to metastatic non-small cell lung cancer with an adenocarcinoma histology. That's where we most commonly see actionable mutations, but it's important to remember that although it's less common, these mutations can also occur in the squamous cell histology. So comprehensive biomarker testing really needs to be considered for all of our patients. Okay, let's break this down into structural alterations, point mutations, and fusions. Starting with structural changes. The classic example is EGFR. The two most common classic mutations in EGFR are exon 19 deletions and exon 21 L858R, which is a point mutation. These are more common in females, younger patients, and never smokers. In Western populations, they occur in about 10 to 15% of patients, and in East Asian populations, more than 30% of patients can be affected. We have multiple approved first-line targeted therapies for these patients. Now, EGFR exon 20 insertions are biologically different. They don't respond to the same therapies that we use for exon 19, and in the first-line setting, approved treatment involves chemotherapy combined with a targeted therapy. So this is a great example of why you can't just think EGFR positive. You have to know which EGFR mutation you're dealing with. Next is ERBB2, also known as HER2. HER2 mutations occur in about 2 to 4% of patients. These patients are often female never smokers. Currently, targeted therapies are approved in the second-line setting and beyond. It's also important to distinguish between HER2 mutation, amplification, and overexpression. They're not interchangeable, so checking the guidelines is key here. Another structural alteration is MET exon 14 skipping. This mutation results in the loss of a portion of the gene and it leads to prolonged signaling. We see this in about 3 to 6% of the patients and tends to be seen in older individuals. We have approved first-line oral TKIs for these patients. So now let's shift to point mutations. A point mutation is a single amino acid change. The number refers to the position in the gene, and the letter tells you which amino acid changed to what. The most common mutation overall in non-small cell lung cancer is KRAS. We see this in about 25 to 30% of patients, and it's more common in those with a smoking history. The specific mutation, KRAS G12C, is targetable and occurs in about 10 to 15% of patients overall. In the first line, standard treatment remains chemotherapy plus immunotherapy or a clinical trial. But in the second line and beyond, we do have approved oral targeted therapies for KRAS G12C. Another point mutation is BRAF V600E. This is relatively rare, about 1 to 2%, and tends to occur in smokers. Unlike KRAS, we do have approved targeted therapy options starting in the first line. So finally, let's talk about gene fusions, also called rearrangements. These occur when two genes become abnormally fused together due to a chromosomal rearrangement. The most clinically relevant fusions involve ALK, RET, ROS1, NTRK, and NRG1. These tend to occur in younger patients with little to no smoking history. ALK rearrangements are seen in about 3 to 8% of non-small cell lung cancer. RET and ROS1 are seen in about 1 to 2%. NTRK and NRG1 fusions are very rare, usually seen in less than 1% of patients. For ALK, RET, ROS1, and NTRK, we have approved first-line oral TKIs. NRG1 currently has approved targeted therapy in the second-line setting and beyond. So it's key to remember that not all mutations within the same gene will behave the same way. EGFR is the perfect example here. The landscape is evolving quickly. This is not an exhaustive overview. Listeners should check the national guidelines for complete information. Beth, earlier you mentioned caring for young female non-smokers years ago when these treatment options weren't available, who unfortunately would die quickly and in retrospect likely had a targetable mutation. Just to underscore the difference that biomarker testing can make, a contrasting example is one of my patients who's in her 50s. She was diagnosed with a non-small cell lung cancer harboring an ALK rearrangement in 2014. She's very active. She's been treated with multiple targeted therapies over the years, and she continues to do really well.
Hey, when I get these reports and I don't understand, I call my molecular pathologist. I know exactly how to get in touch with them, or I email them right away. This just happened recently. I'm like, this says RET, but you have it under a DNA variant of uncertain significance. So what is that? And they're like, well, remember, Beth, a RET is a fusion gene. So this RET that we reported is not fused with another gene. It's actually some sort of DNA mutation that is not the type of RET that would be actionable. I said, well, how would I know that? And then they went into some spiel about what a fusion looks like on their report. But just ask, because usually on the report, it'll say disease-associated variant, which is usually something actionable or associated with the disease. And then you'll have a point that says VUS, or variant of uncertain significance. When listed under there, that's your pathologist telling you, we're not sure what this means. It's uncertain if this has any kind of disease-associated implication, but it might not. So that's one thing you can sort of look out for immediately.
Yes, for sure. And this is where the devil really is in the details, right? I mean, it's not enough to know it's an EGFR mutation. You have to know which one. We have to know what the mutation is. EGFR amplification is not the same as a mutation. The other one is like a KRAS G12C, and these are our two most common, right? Our KRAS and our EGFR. KRAS G12C, V like Charlie, is not the same as KRAS G12V, V like Victor. One is targetable, one currently has no FDA approved treatment, right? So it's not enough to just see that mutation. You really have to understand the specific mutation it is. It is nice that the College of American Pathologists at the end of last year put together some guidelines where they are working on a standard for reporting of NGS so that each company you go to, everywhere you go, it's going to have a standard and more readable NGS. And as that's rolled out, I think that may help. But yeah, you really have to look carefully.
You would love that. And I think, to summarize that, just call the company, call the molecular pathologist, whatever it may be, if you're not sure, because you need to be sure on this.
Yeah.
Before you select therapy based on it. And it can be really confusing. So don't feel bad, guys. Denise and I do this every day for a living, and we still don't know every time. So do not feel bad if you don't understand it, because we don't always either. Let's transition a little bit and talk about what our APP role in treatment selection is. This one is a little bit harder. I think, Denise, you and I have been doing this a long time, so I probably have a little bit more of a comfort level. I certainly didn't in the beginning and wouldn't, and that makes sense. I think it depends on the biomarker also. So like, for example, if you have somebody who's ALK positive, who has, a low PD-L1 expression, I mean, that's a slam dunk. We know what we're doing. As a matter of fact, it's a slam dunk even if they have a high PD-L1 expression, because the answer is still an ALK therapy. It's way better than immunotherapy or chemotherapy would be in these patients. The treatment decision really is up to the oncologist at the end of the day. But I think we a lot of times probably start the conversation when we see one of these reports. I mean, if we're the one who gets the report back, I would often call a patient and say, there's a pill that we're likely to start you on. What are your thoughts? Do you feel like you have a role in the treatment selection?
I think medicine in general is a team sport, but especially oncology. And so what we do is our physicians are going to make that treatment selection. I think that's totally appropriate. But as you said, we will often educate the patient as to what might be expected. Like you said, if we're seeing the report before that patient's back in to see the physician, certainly educating them after they're given that drug, monitoring them, helping monitor toxicity, helping them understand their disease, answer their questions. And we talk about, we talk about all of our patients every week. Every patient's going to be seen the following week. We talk about together as a team. And so, sometimes the physician will say, "Hey, you've seen this person quite a bit. How hardy do you think they are? How do you think they might tolerate whatever this treatment is?" And so we work together as a team to understand what the best option is. But the physician makes the treatment decision always.
Yeah. And then that sort of leads into our joint decision making and shared decision making, which is a big deal now in oncology. And I think back, like I said, 20 years ago, we had like paclitaxel and carboplatin and not much more. So there wasn't a ton of shared decision making going on because we didn't have really many options. It was like treatment, no treatment. Now, we have a lot of options for patients. Even in particular, I mean, what did we just talk about? ALK? There are six now. There are now 6 drugs approved just within that setting. So we can talk with patients about what some of the toxicities are of different agents. We talked to our APP survey and we asked them, how confident are you in your ability to explain to patients the difference between something like a PD-L1 status, NGS results, and histology? A lot of people said they weren't all that confident, actually the majority. And then the people who said they were really confident were probably the people that just do lung cancer for a living, I'm guessing. I don't know to that level. But there were certainly people who said they don't feel real confident in, explaining the differences of this and helping the patient make that shared decision making. What are your feelings about that?
I think if you understand this base level, the nice thing is you can learn this piece and then it applies to all of our targeted therapies, right? These are the basics. This is the foundation for all of our targeted therapies. And so if you're able to talk to patients and explain, the histology is that this is an adenocarcinoma. That's what it looks like underneath the microscope. That's what the pathologist is seeing, and it helps us identify where the cancer is originating from. So that's that piece of it. But then, that can be confusing for but wait, you said I have EGFR or a PD-L1. How do you explain to them like the difference between PD-L1 and NGS?
Well, I would certainly say to them, a PD-L1 is an expression level, right? This is something that is looking at a percentage of the protein on your cell that might predict for how you might respond to immunotherapy. But NGS is different. These are actual driver mutations within your cells that we have targeted therapies that will absolutely change the outcome of how we treat you. So that might be some way that I would explain it to a patient.
And
And
they're
then
all pieces of the puzzle, right?
yeah.
You need
Yeah.
all those pieces to make the best decision.
And then I think making the best decision with the patient also comes from our ability as APPs to communicate with the specialists. My experience usually is that they are happy to talk to us about it and explain it to us because it can be confusing. In our survey, the other APPs, the majority felt that they were either very confident or extremely confident in collaborating with their medical oncologist, with the rad onc, with the molecular pathologist, because I think we all are speaking the same language and we're all doing this. But I want to make sure that, for all our listeners, like you can talk with these other specialists.
I have the same experience as you, where the vast majority of the time, people are happy to give advice. They're happy to share their expertise. just ask the question. If it's not an urgent question, send an email. If you can get the answer tomorrow, if you're worried about interrupting someone, at least just send them an email. And the worst that can happen is they can say, talk to your doctor, or I don't want to answer this question. But it's always worth asking because most people will share their expertise. And it's one of the best ways to learn more about this process is to actually get that insight from somebody who has some special knowledge.
Agreed. Well, let's finish out by just talking about health inequity regarding biomarker testing. And, there's certainly literature out there. And among our overall respondents, all 39 of them, actually, this was not just the APPs, but physicians, nurses. Out of all of them, 82% said they definitely feel like they have noted health inequity regarding testing. And let's talk a little bit about that. I think, for me, something I always come up with is worry about insurance and whether it's going to be covered. And for patients who may be on a Medicaid plan or some sort of, plan that might not be as strong. And again, this goes back to what you and I said earlier, that should not be a factor. That, even our patients, this is covered by medical assistance, it's covered by Medicaid, it's covered by Medicare. So that should not be a reason that we don't test patients. I think health literacy might come into play here and our ability to make sure we're explaining this to patients no matter what their education level is. We have to be able to explain this. And you did a great job of giving an example of that earlier. What do you feel in your practice have you seen inequity within biomarker testing in lung cancer?
I think you've hit on two of the major areas. One is if we don't test because we assume either because of their socioeconomic status, the type of insurance they have, we assume they can't afford this coverage. Or if we say it's an 80-year-old smoker, they don't really need necessarily this biomarker testing. We know what's going on. It's unlikely. Those people then are going to have, we're just not going to know. People who can be treated, who can really have better outcomes, they're going to miss those opportunities. And the other thing that happens is I do think that this also leans into the fact that we have disparity in clinical trials. Many of our clinical trials are targeted, and if we have that information, then those same patients may be eligible for some clinical trials, and we'll have more people that have access to those opportunities.
Yeah. That's a great example. I'm going to just finish up with, I'm just going to tell you one of my own personal stories about something very similar to this. This was years ago. I had this very elderly African-American male, heavy smoker. I think he was still smoking at the time. He always came alone. Him and I developed a relationship over time because we'd been treating him with chemotherapy and immunotherapy for over a year. He was really debilitated. He's, one of those guys that I said, can I get you a wheelchair? No, I don't need one. And he's walking with his walker and I'm walking behind him down the hallway thinking, oh my goodness, I'm going to catch you when you fall. He was so cute. And we just had this great relationship over the years. And when he progressed on second line therapy and, I thought, well, I think this is it. This is for hospice. And I'm thinking, this guy has adenocarcinoma. Did we ever test him? So I go back and I look, and we did test him. But for whatever reason, and this was many years ago, it was like not in the EMR in a place that I could really find it. And, it wasn't a top on my radar. This isn't like an Asian female never smoker, like somebody who I'm thinking definitely is going to have a mutation. So I'm like, I literally was ready to make the hospice call. I'd already talked to the doctor and we went back. Like, did we ever test him? And sure enough, he had a KRAS G12C. And we didn't see it because I think in my own mind, I was just thinking, well, he doesn't fit the picture of someone who's likely to have an actionable mutation. And he had no one there supporting him or advocating for him. If you think about that, it was just him and his health literacy was not good. And here's me with my own unconscious bias, not thinking that this is someone likely to have a mutation. And sure enough, he had a KRAS G12C. And we did put him then on targeted therapy because it's oral, didn't have a lot of side effects. So we didn't have a big downside to that. But I think in that's a good realistic case of someone who I had unconscious bias towards that I didn't think that would be a candidate for this. So this is something that you have to remember. All patients can have a targetable mutation. And we need to be looking and advocating for them, particularly when they don't have someone else there with them who's also saying, hey, do you know your biomarker status? Did you look it up?
And
So
I think your story illustrates a couple of really good points in there. One is that part of the reason we need to do broader testing is because although that target isn't available today, it doesn't mean that there's not going to be a treatment available for that target 6 months from now or a year from now when they progress. KRAS G12C, it's a common mutation, but there wasn't treatment for it for a lot of years, right? And so it's easy to overlook that
yeah,
later on. You got to go
right.
back and you got to look.
Yeah.
And some of those mutations, like the KRAS G12C or the BRAF V600E, we see those in smokers. So
Mhm.
we do see some of these mutations in different smokers. The one other thing I wanted just to bring up is resources. I know that that was something that was asked by some of the people in our survey. And one of the things they asked for is like, do you have a one-page list of the drugs and the biomarkers? And we actually do. So if you go to the NCCN, which is the National Comprehensive Cancer Network, which is the standards for cancer in the United States, you do have to have a subscription, but it's free. So in other words, you do have to put in a username and a password to get access, but there's no charge to that. They have great algorithms and flow sheets to tell you by stage, what do you do next? You can follow that along. And there's a one-page biomarker directed therapy that talks about our targeted mutations and the drugs that are approved for that. ASCO also has a, they call it a living document. So it's an article that is out there that is continually updated that gives you more detail. So if you see, like you said, it's an ALK fusion and there's 6 therapies and you're like, well, where do I go with this? If you go to ASCO, there's a nice little ALK, here's the drugs, and there's a nice little maybe half page. It's not real onerous information that tells you, here's the studies, this is what they resulted from, here's where we got these drugs, these are some recommendations for how to sequence these drugs. So there are some resources that aren't really hard to work through that are going to help you get more information.
Thank you, Beth, and thank you, Denise, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, the APP Guide to Actionable Biomarkers in Solid Tumors, Reducing Barriers, Promoting Confidence, and Leveraging Genetic Testing for Informed Treatment Decision-Making, and to access online resources associated with this discussion, please click the link in the show notes. Thanks for listening.